This unit deals with water and electrolyte imbalances, as well as acid-base imbalances. Before reviewing this video, please make sure you listen to this short review video on transport across the cell membrane. This will especially help in understanding water transport and water movement in and out of the cells. There are two factors that can play a role in fluid imbalances. One is the link between sodium and water. Sodium accounts for half of the osmolarity of the extracellular fluid. Osmolarity refers to particle concentration, so over half of the particles in the ECF are coming from sodium. A change in the level of concentration of one, be it sodium or water, will have a significant effect on the other. The second factor relates to defects in mechanisms that maintain body fluid concentration and volume homeostasis. Note, often when we use the term volume, we refer to both water and sodium, because typically where sodium goes, water will follow. First condition is dehydration. This is a decrease in total body water, but total body sodium remains near normal. This could be due to a decrease in water intake or excessive water losses. Who is at risk? Children, elderly, bedridden, crippled, or impaired. Basically anyone who is at the mercy of others in order to get water. This may result in a decreased intake in these people. It may also result from various disease conditions, both forms of diabetes. Diabetes insipidus, where the increased losses of water are due to decreased ADH secretion from the anterior pituitary. ADH is antidiuretic hormone, which causes you to retain water. So if there is a decrease or secretion is suppressed, you would retain less water. Diabetes mellitus, here you see an osmotic diuresis. There's an increase in glucose in the urine, increased particle concentration, and this draws water out. The net result, if the body senses it is developing dehydration due either to an increase in ECF osmolarity or a decrease in blood pressure, first it will activate the thirst drive. But if the person is dependent on others, or if they have a defective thirst drive, severe dehydration can develop rather quickly. Body fluids soon become hypertonic. Remember, sodium levels are near normal, but water volume has decreased. This condition is referred to as a relative hypernatremia, high sodium levels. The effect is due to water loss, not a true sodium increase. Hence, it is given the term relative. Water intoxication is an increase in total body water with no changes in total sodium. This ends up diluting the ECF. This condition rarely develops due to the efficiency of the kidneys. How could it occur? It may be due to impaired water excretion due to an excess of ADH secretion. This condition would be known as SIADH, Syndrome of Inappropriate ADH Secretion. Here, excessive ADH is released when there is no physiological need. Another cause could result from disturbances in the central nervous system due to infection, trauma, cerebral hemorrhage. This ends up being a problem in the control system that regulates ADH secretion. What happens often is that you get a lower set point for overall body fluid osmolarity. For example, the normal set point is around 300 milliosmol, but now the set point has been lowered to 250. If blood is coming through with an osmolarity of 300, the control center senses that there are too many particles. So it will set into play mechanisms to cause the body to retain extra water to dilute out that 300 milliosmol to 250. It could also be due to tumors that secrete antidiuretic hormone. Could be due to the lung secretion of ADH. This is commonly seen in association with tuberculosis, asthma, and COPD. Also, various drugs could result in impaired water excretion. This will result in a relative condition. Sodium levels will appear normal, but it is relative to an increase in water concentration. More common, it is to see both sodium and water involved, not just one or the other. Note that they don't have to be altered to the same degree. If sodium losses are greater than water losses, this will create a hypotonic ECF. This chart represents various conditions where both sodium and water are lost, and in many times lost or gained, but at many times to different degrees. If you can understand what is happening in this chart, you have a very good understanding of how water and sodium move. Looking at this chart, first column to pay attention to is the ECF volume. This is what we can measure. We can measure the actual volume. We can measure the particle concentration here. ECF refers to the plasma, the extracellular volume. ICF refers to the volume of the cell, and this is relative to shape changes in the cell. Sodium change, we will be measuring sodium. This refers to the sodium that is present in the ECF. All right, so we're going to start with the easiest one, which is normal saline infusion. This is giving, to replace volume, you would give normal or isotonic saline. If you are giving fluids, this would be an expansion. This is given into the plasma, so it will result in an increase in the ECF. It is referred to as normal saline because it is isotonic to the plasma. It has the exact same sodium concentration as the plasma. So you can add volume but cause no change in the overall sodium concentration. Because there is no change in the sodium concentration, this will result in no change to the cell volume because the concentration of sodium remains the same on either side of the cell membrane. Let's go up to chronic diarrhea. Chronic diarrhea, you are losing water. Okay? It's a decrease, so you're going to see a decrease in ECF. With chronic diarrhea, usually sodium and water are released at the same amount. So you will, even though you are losing volume, you will not see a change in overall sodium concentration. This is known as an isotonic depletion. Because it is isotonic and there's no change in sodium concentration on either side of the cell membrane, the cell volume does not change. With intense perspiration, and you are losing water, and usually you lose water to a greater extent than you do sodium. So it is a depletion. You will see a decrease in the ECF as it loses water volume. But because you are losing water faster than sodium, you will see an increase, relative increase in the sodium concentration in the ECF. Now it appears that there is more sodium outside of our cell. We need to dilute that sodium. Where are we going to get the water? We get it from the cell. So water will leave the cell. This will cause a decrease in the ICF volume. Water leaves the cell, goes into the ICF to try and decrease the relative sodium concentration. Renal sodium loss. Again, it's a depletion, but now you are losing more sodium compared to water. So you're still losing water, so you're going to see a decrease in the ECF, but because you're losing more sodium compared to the amount of water, you will see a change in the sodium concentration. The sodium concentration in the ECF will decrease. Now it appears that there is more water outside of the cell compared to inside, and more sodium inside the cell. So water will move into the cell to try to dilute out the sodium here, and the volume will increase, and our cells can increase in size. A hypertonic saline infusion. All right, so we're expanding the ECF, we're putting volume into the ECF, but it's a hypertonic saline. It is a greater sodium concentration compared to the plasma. So this is going to increase the overall sodium concentration in the ECF. Because now there is more sodium in the ECF, we need to dilute it out. And once again, the water will come from the cells. The ICF volume will decrease as water leaves the cells and goes into the ECF. Finally, water intoxication. This would be equivalent to injecting pure water into the plasma. So you're going to see an increase in ECF volume. But because there is no sodium, it will cause a relative decrease in the overall sodium concentration. Now the cells appear to have more sodium compared to the ECF, so they will take up some of that water, that excess water, and the volume of our ICF will change. Looking at volume depletion, this results when water and electrolytes are lost from the ECF. Many of these scenarios are what we just looked at in the last chart. Heavy perspiration, vomiting, diarrhea, intestinal resection, and GI fistulas. Both of these end up reducing the surface area for absorption. Kidney diseases that interfere with sodium reabsorption or reduce aldosterone output. Improper diuretic therapy, skin burns that result in exaggerated evaporation losses, and third spacing, where you see rapid blood loss or inflammatory exudate. This picture here shows how you can lose volume. This represents the mouth area. This represents exuding. So it could be due to a reduced intake or vomiting, diarrhea, renal disease, excessive sweating, reduced absorption, hyperventilation, because every time we exhale, not only do we get rid of CO2, we also get rid of water, skin burns, and third spacing. Volume excesses are mainly due to renal sodium and water retention. This could be the result of kidney, liver, or cardiac disease that promote water and sodium retention. In kidney failure, the kidneys lose their ability to excrete sodium, so the body holds on to sodium. Because it's holding on to more sodium, it will then also hold on to water, and this will cause the ECF volume to increase. In congestive heart failure and cirrhosis, this will result in edema and ascites buildup. Nephrotic syndrome, this is another problem with the kidney. In nephrotic syndrome, you see urinary protein losses. This can result in edema due to a decreased plasma osmotic pressure and activate the various above mechanisms. Protein, if we start losing protein is a main particle concentration of the plasma. So as protein levels fall and are excreted due to nephrotic syndrome, there will appear to be less in the plasma. This will make the plasma appear to have more relative water, and this water will go out into the tissues, resulting in edema. This could also be the result of aldosterone hypersecretion. Aldosterone is a hormone that causes the body to conserve sodium and excrete potassium. Again, if you have hypersecretion of aldosterone, you will be holding on to more sodium. The more sodium you hold on to, the more water you will hold on to. This could be due to a tumor, or it could be due to adrenal cortex hyperplasia. Aldosterone is produced by the adrenal cortex. This flowchart shows the consequences of fluid imbalances, which we will be looking at. Volume increases or decreases will produce both circulatory and osmotic effects. First, the circulatory effects. An increase in plasma volume beyond correctable levels can result in systemic edema and also an increase in blood pressure. Decreased plasma volume beyond correctable levels will result in an increase in hematocrit. So as you lose water, it will appear that the packed cell volume is greater. It can result in shock, and it can set into play fluid retention reflexes. These occur when the plasma remains isotonic. Patients will become thirsty, will exhibit a dry mouth, decreased perspiration, decreased urinary output, and changes in skin turgor. The other effect, it would be an altered ECF osmolarity. What would the effects here be? You will see either shrinking or swelling of the cells, and the cells most sensitive are those in the central nervous system. In states of dehydration, the plasma will become hypertonic. As you lose water, the particle concentration will appear greater. If the plasma is hypertonic, has too many particles, it will draw the water out of the cells in an attempt to dilute this. This will cause the cells to shrink. If volume depletion is due to sodium losses greater than water losses, now the plasma will become hypotonic. Water will enter into the cells and they will swell. In water intoxication, this too will make the plasma hypotonic, causing the cells to swell. In renal malfunction, you will see an increase in sodium retention, making the plasma hypertonic, and this will cause the cells to shrink. Now, what happens as a result of the swelling or shrinking? With cerebral shrinkage, this can result in weakness and irritability, seizures, coma, and death. If it occurs rapidly, it also can result in cerebral hemorrhaging. With cerebral swelling or cell swelling, this will cause cerebral edema. This can result in headaches, nausea and vomiting, malaise, and in severe cases, or as it progresses, seizures and coma. Therapy and fluid imbalances. If the depletion is due to hemorrhaging, try to replace with blood. One can also use normal saline. This will restore volume and plasma concentration. If the kidneys are fine, they will correct the sodium and water imbalances as long as they have enough volume to work with. You can also use diuretic therapy. This can restore volume, especially if the kidneys are not able to compensate. Next, we will look at some of the important electrolytes in the body and what happens when their concentrations become imbalanced. The first is sodium. First condition is hyponatremia, low levels of sodium or sodium deficiency. This is usually the result of body fluid loss and not an inadequate intake of sodium. Let's face it, we all love our salt and get plenty in our diet. This condition is also usually relative. It is the result of excessive body water and not a true sodium loss. True sodium losses could occur due to renal defects or due to a decrease in aldosterone, but these are usually quickly matched by water loss to return to an isotonic ECF. Hypernatremia, this would be an excess in sodium, usually arises when water loss is greater than sodium loss. This condition, too, is often relative. True conditions are rare, but can occur if therapeutic administration of sodium chloride is excessive, and this then could result in systemic edema. Another important electrolyte is potassium. This is the dominant cation in the intracellular fluid inside of our cells. There is 40 times more potassium inside of our cells compared to the ECF. As a result, it plays a key role in the osmotic determination of cellular volume, maintaining normal cell volume. It also contributes to membrane potentials in both nerves and muscles, so it plays an important role in neuromuscular activity. How can we lose potassium? We lose small amounts through perspiration and through our feces. We lose the most potassium through urine, and this is one way is through tubular secretion. The kidney tubules respond directly to how much potassium is in the renal interstitium, and if there's too much in the renal interstitium, they will dump it or secrete it into the urine. If there is too much secretion, this can result in a loss. The kidneys also respond to circulating aldosterone. Remember, an increase in aldosterone causes an increase in sodium retention, and at the same time, an increase in the amount of potassium that will be excreted. Hypokalemia, this is what is referred to as low potassium levels. This could be the result of a total body deficit, and we don't get enough in our diet. It could be due to shifts of potassium from the ECF into the cellular component. Remember, we need to maintain 40 times more potassium inside the cells. These shifts could result from insulin therapy. This is something that you need to watch out for. Glucose and many drugs will stimulate the cellular uptake of potassium. Also in alkalosis, which we will be talking more about in just a little bit, potassium will shift into the cells, and this can cause an acid imbalance. When a person is suffering from alkalosis, their pH is too high. In order to lower the pH, a good source of hydrogen ions are found inside of the cell. So hydrogen ions will come out of the cells to try to balance the pH. Hydrogen ions carry a positive charge. We need to balance the charge. So potassium will be shifted into the cell to exchange these positive ions. So for every hydrogen that comes out of the cell, one potassium will go in to balance the charge, and this can create a hypokalemia state. Another cause could be inadequate dietary intake. This can be seen when the appetite is depressed, very common in the elderly, when there's a GI disturbance, nausea, or just an overall aversion to eating. Another cause could be vomiting, heavy perspiration, and chronic diarrhea. This is commonly seen, a decrease or an imbalance of potassium is seen with people who abuse laxatives. It could be due to an absorption difficulty, either a GI fistula or an intestinal resection that results in a decrease in the ability or decreased surface area for absorption. It could be due to a kidney tubular reabsorption defect, so the kidneys cannot reabsorb potassium from the urine, hypersecretion of aldosterone, various drugs such as diuretics, and the improper administration of IV fluids. This flow chart is exactly what we just talked about, all the different causes of hypokalemia. Instead of words, just put into a flow chart form. Signs and symptoms of low potassium. You will see disorders in neuromuscular function. Muscles will become weak. You may experience muscle twitches and a depressed neuromuscular reflex. You will also see loss of neuromuscular tone. There can also be vomiting. In the EKG, you will see some significant changes as well. The top trace is a normal ECG. The bottom is the result of low potassium. You will see a flattened T wave and a prominent elevated U wave. Hyperkalemia, this is potassium excess. This scenario can be life-threatening. This could be due to aldosterone deficiency. Now you would see an increase in potassium retention. It could be due to renal failure, excessive IV fluids, excessive trauma, for example, crushing injuries. When cells are damaged or crushed, this will cause the potassium to be released from the damaged cells. Remember, 40 times more potassium. This is a lot of potassium to be released all at once into the ECF. Hemolysis. Again, red blood cells have the same levels of potassium. When red blood cells are damaged or lyse, all this potassium will be released. Same happens with stored blood. Donated blood has a finite lifespan. One reason is that potassium leaks out of the cells over time. This can lead to hyperkalemia in a recipient after transfusion. Acid-base imbalances can result in hyperkalemia. We'll see how this happens in just a moment, and insulin deficiency. The main result that we see of hyperkalemia is in an ECG. It will result in arrhythmias. All elements of the ECG are abnormal. The ST segment will be depressed, the T wave is increased, and the P wave is lost. The next electrolyte is calcium. In the ECF, we tend to have 2 times more calcium than what is present in the ICF, so it's more prevalent in the extracellular fluid. Calcium is typically present in 2 forms, ionized, which is free calcium, and calcium in the bound state, bound either to citrate or to protein. It is only the free calcium that contributes to calcium concentrations. When we measure calcium, we are measuring the amount of free calcium. Homeostasis for calcium is maintained via 2 hormones. The first is parathyroid hormone. Parathyroid hormone will stimulate the GI tract to increase the absorption of calcium. And it also stimulates the kidneys to retain calcium. And it also mobilizes calcium from our bones. The other hormone is calcitonin. Calcitonin promotes calcium excretion to prevent excess. So these two hormones work together to maintain balance. Hypercalcemia. This is high levels of calcium. This could be the result of hyperparathyroidism, increased levels of parathyroid hormone, or hypothyroidism, which is a decrease in calcitonin. Either way, these would result in calcium retention. It could be due to renal disease that suppresses the excretion of calcium. It could be due to an excessive intake of vitamin D. Vitamin D is needed for calcium absorption. It could be due to tumors that secrete materials that behave like parathyroid hormone. Often this condition occurs along with hypophosphatemia because calcium retention in the kidney is linked to phosphate excretion. So you will see an increase in calcium along with a decrease in phosphates. Symptoms of hypercalcemia: muscle cramps, pain, nephrolithiasis, which are kidney stones, GI hyperactivity, nausea, cramps, and diarrhea, and widespread deposition of calcium in the tissues. This flowchart represents hypocalcemia. I have this one just in a flowchart, no words. Hypo, or low levels of calcium, could be due to a dietary lack of vitamin D. It could be due to reduced parathyroid hormone due to suppression of the parathyroid, hypersecretion of calcitonin, and malabsorption syndromes because calcium absorption depends on the acidity of the intestines. So abuse of antacid or gastric resection would have an effect on calcium levels. It could be due to systemic infections and peritoneal inflammation. Both of these scenarios promote an increase in calcium binding. So more calcium will be in the bound state and less free calcium will be available in the ECF. Therapy in fluid and electrolyte imbalances: first, attempt to correct the initial cause of the imbalance, and then take care of the losses or excesses later. If it's a deficiency, one can use IV fluids and electrolyte replacement. You can also use IV infusions to produce the appropriate changes in the plasma osmolarity. If it's due to excesses, diuretics can be used to stimulate water loss. These can depress nephron sodium reabsorption. They can interfere with the reabsorption of chloride, which would also affect sodium. And they can reduce the response of the nephron tubules to antidiuretic hormone. The last major imbalance to look at is acid-base imbalances. This is important because many physiological reactions in the body depend on pH. Most enzymes function within a very narrow pH range. Even slight changes will cause problems. Imbalances will also affect electrolytes and can disrupt homeostasis. Acidosis is considered to be when the pH of the plasma falls below 7.35. Alkalosis is when the pH rises above 7.45. Normal is 7.40. So this is not a very big change in pH, but even these small changes can result in serious problems. To maintain proper pH, one must control the concentration of hydrogen ions. Slight changes in hydrogen ions can alter the rates of enzyme reactions, cause shifts in the distribution of ions, and modify the actions of hormones. So when we refer to acid-base balance, we are concerned primarily with regulating the concentration of hydrogen ions. Well, where do these hydrogen ions come from? Most are the result of byproducts of metabolism. For example, aerobic respiration of glucose, which is how we get the majority of our energy, our ATP. When glucose is completely broken down in aerobic respiration, it results in the formation of carbon dioxide and water in the cells. Carbon dioxide is a waste product, and it will diffuse out of the cells and into the plasma. When it's in the plasma, CO2 will react with the water in the ECF, and as a result, produce carbonic acid. Carbonic acid will ionize into bicarbonate and hydrogen ions, and then these free hydrogen ions contribute to pH. Anaerobic respiration of glucose, this will create lactic acid, which also ionizes, releasing hydrogen ions into the body fluids. When the body breaks down fatty acids, it is often an incomplete oxidation, and this produces acetic ketone bodies. Oxidation of amino acids containing sulfur will produce sulfuric acid, and the breakdown of proteins in general result in the production of phosphoric acid. Both of these are very strong, very potent acids. There are three ways to control hydrogen ion concentration in the body. The first way is through buffering systems. To maintain the correct pH, we need to excrete hydrogen ions at the same rate that they are produced. Only free hydrogen ions will contribute to the acidity of the body fluids. If these hydrogen ions are taken up by another molecule, it is no longer free and can no longer act as an acid. This is the function of a buffer system. There are three main buffer systems in the body. The first is the bicarbonate buffer system. This is found both in the ICF and the ECF, and this involves bicarb. The phosphate buffering system plays an important role as a regulator of hydrogen ion concentration in the tubular fluids of the nephrons and the urine. Protein buffering systems involves plasma proteins, specifically albumin and hemoglobin. So this is showing these buffering systems. So in the ICF, you have the protein buffering system, the phosphate, and the bicarb. Here's the bicarb in the ECF, the phosphates, and the protein buffering system. The second way to control hydrogen ion concentration is via the respiratory center. The respiratory center is found in the brainstem, and this helps to regulate hydrogen ion concentration in the body fluids by controlling the rate and depth of breathing. Let's take an example. If the concentration of CO2 increases, for example, we're exercising, the more as we exercise, we're going to use more glucose for energy, and this is going to create more CO2. As the levels of CO2 increase, this will result in an increased production of carbonic acid. As the carbonic acid dissociates, you will see an increase in hydrogen ions, and the pH will begin to drop. As the plasma travels through the brain, it will stimulate chemoreceptors in the respiratory center. The respiratory center responds by causing the depth and rate of breathing to increase. This results in more CO2 being released from the body via the lungs. As more and more CO2 is blown off, you will see less hydrogen ions in the body fluids, because these hydrogen ions, or the released CO2, comes from carbonic acid. The opposite would occur if the body is less active. The third way to control hydrogen ion concentration is through the kidneys. The kidneys excrete acids produced by protein and lipid metabolism. The kidneys can also reabsorb filtered bicarb and generate more bicarb to replace what was lost through the buffering systems. Now, make sure you understand this picture. The brownish structures, these represent the cells of the kidney tubules. On this side of the cells, this would represent potential urine, and this represents the body. Any arrow going to the right represents a material that is being reabsorbed back into the blood, back into the body. Any arrow going to the left represents a material that is being secreted into the potential urine. So the nephrons of the kidneys help to regulate hydrogen ion concentrations of body fluids by actually secreting hydrogen ions. These hydrogen ions, we can see it here, are secreted into the urine of the renal tubules by the epithelial cells that line the proximal and distal convoluted tubules, as well as the collecting ducts of the kidney. The local production of hydrogen ions for excretion will use carbon dioxide from the plasma and the kidney's own metabolism. The CO2 plus water will become carbonic acid and then dissociate into bicarb and hydrogen ions. The hydrogen ions will be secreted and into the urine, and at the same time sodium will be reabsorbed. Again, this is a charge issue. Hydrogen ions have a positive charge. If we start dumping positive charges, we need to reabsorb something that also has a positive charge. That would be sodium. So as hydrogen ions are secreted, sodium will be reabsorbed to balance the charge. The bicarb that's produced often enters into the blood and now is available for buffering in the ECF. As a result, the excretion of an acid is directly linked to the retention of a base. Now, at the same time the secretion of hydrogen ions is going on, the glomeruli are filtering. So filtration is still occurring at the glomerulus. This filtrate often contains a large amount of bicarb. This bicarb now will combine with the secreted hydrogen ions, forming carbonic acid. There is an enzyme, carbonic anhydrase, in the epithelial membrane of the renal cells. This will break down the carbonic acid into water or the CO2. This CO2 has the potential of going back into the blood, and this could just complicate the problem. We're trying to excrete acids. Now we're picking up more CO2. This has the potential to create more acids. Normally, though, the amount of fixed acids slightly exceeds the amount of bicarb available for combination. So usually the excretion or secretion of hydrogen ions is going to be greater than the number that will combine with bicarb and come back into the body. However, the body produces above normal amounts of acids. You can see an increase in hydrogen ion concentration in the urine because there would not be enough bicarb. These excess hydrogen ions would be secreted and excreted from the body, and the pH of the urine would decrease. If acid production decreases, then you would see more bicarb in the urine. Now, we want these hydrogen ions, once they're secreted, to be a permanent loss. So in this way, once excreted, we don't want this hydrogen ions to diffuse back into the kidney tissue. This is prevented by the tubular secretion of NH3. This NH3 will pick up the hydrogen ion and create NH4. Once it is in this state, NH4 cannot be reabsorbed back into the tissues, and this will create a permanent loss of that hydrogen ion. Notice too, for every hydrogen ion that is secreted, we see a sodium ion being reabsorbed. Now, with these three systems, buffering in cells will respond to pH changes in a matter of seconds. The respiratory system, these responses take several minutes to kick in, and the renal mechanisms can take several hours to respond. However, once these mechanisms do kick in, they have the ability to compensate for an extended period of time. Now, acid-base imbalances, hydrogen ion imbalances, will result in other related ion effects. This altered pH in the ECF can produce secondary changes in the levels of other ions. First is potassium. With acidosis, all these excess hydrogen ions will diffuse into the cells. There is a much lower hydrogen ion concentration inside the cells. Now, this is a problem because it will cause positive charges to begin to accumulate in the cells. We need to balance these charges. So as hydrogen ions accumulate inside the cell, this will cause potassium to move out of the cells. This can result then in hyperkalemia. So you start with acidosis, and while the body is trying to correct the pH imbalance, it will create a secondary hyperkalemia. The opposite occurs in alkalosis. If the potassium imbalances are first, then you will see a secondary acid-base shift. For example, if the person started with hypokalemia, they have reduced potassium level in the ECF. Where is the biggest source of potassium? Inside the cells. This will result in potassium diffusing out of the cells. Again, we need to balance that positive charge, so the hydrogen ion begins to diffuse into the cells. We started with hypokalemia, and we ended up with a secondary alkalosis. Sodium ions. As sodium is exchanged for hydrogen at the level of the kidney, this will cause pH shifts to occur. If the EC volume is excessive, too much volume, this will cause a decrease in the amount of sodium reabsorbed by the kidneys. The kidneys will not reabsorb as much sodium. As a result, if they can't reabsorb sodium, you're going to see a decrease in the ability to excrete hydrogen ions. Hydrogen ions will build up, and this can create acidosis. With calcium, the binding of calcium to protein or citrate is acid dependent. So when a person is acidotic, more calcium will be found in the bound state, and this can result in hypocalcemia. This chart just shows the links between sodium and calcium to acid and base imbalances. Aldosterone. Remember, increased aldosterone causes an increased sodium retention and a decrease in potassium levels. If you see an increased secretion of aldosterone, this often occurs in response to diuretic theory. This increase in aldosterone secretion can result in hydrogen ion loss, resulting in an alkalosis. A decreased secretion of aldosterone will result in a decreased secretion of hydrogen ions and potassium at the level of the kidney, and this can result in concurrent acidosis and hyperkalemia. Now we're going to look at the patterns of acid-base imbalances. The carbonic acid system and the state of the carbonic acid buffer system in the plasma is used as an indicator of the pH of the ECF. Again, this is because the plasma is easily analyzed. Most common way of analyzing the plasma is to use the Henderson-Hasselbalch equation, which is shown here. Please relax. I will never ask you to solve this equation. Bicarb, HCO3, indicates a metabolic condition. PCO2 relates to carbonic acid and indicates a respiratory condition. Normal ratios between bicarb and CO2 to maintain a pH of 7.4 is about 20:1. Any change in pH is due to a change in this ratio. PCO2 refers to the partial pressure of carbon dioxide. This will be altered by anything that changes your ventilation. Bicarb will be altered, or the bicarb concentration will be altered usually by the renal excretion of hydrogen ions. Anytime the ratio falls below a 20:1, this would indicate an acidosis. There is an easier way to figure out acid-base imbalances. There is, posted on Blackboard, there is a practice case study that I want people to look at and especially try to figure out the 8 scenarios of acid-base imbalances in the one question. The key to these is first start with the pH. That will tell you if the condition is acidosis or alkalosis. Anything below 7.4 would be acidosis. Anything above 7.4 would be alkalosis. Then you need to determine if it is a respiratory or a metabolic condition. Use these guidelines. If you see an increase in the PCO2, and the key is increase in concentration greater than 45, this represents respiratory acidosis, irregardless of what the other numbers are. If the CO2 is greater than 45, it is respiratory acidosis. If you see a decrease in the partial pressure of CO2 below 35, this would indicate respiratory alkalosis, again, irregardless of what the others are. If you see the bicarb greater than 26, this will indicate metabolic alkalosis. If you see the bicarb decrease below 22, it is metabolic acidosis. Apply these numbers to those 8 scenarios in the practice case study. Some scenarios will have more than one thing wrong with this person, but look at the CO2 numbers, look at the bicarb numbers. Where do they fit in this chart? And that will describe what the condition is. Respiratory pertains to changes in ventilation and will cause changes in the partial pressure of CO2. Metabolic is due to changes in acid production, renal excretion of acids, or digestive losses. Now, one thing, too, you will note with the practice case studies that all the numbers are in many cases are going to be out of whack. This is because the body will try to compensate to maintain the proper ratio. If the concentration of bicarb is decreasing, for example, due to excessive acid production, compensation will be achieved by reducing the CO2 levels through hyperventilation. If lung disease causes a decrease in the ratio, then the kidneys will try to compensate by increasing the hydrogen ion secretion. Now let's look at the 4 scenarios. Respiratory acidosis. This is due to a decrease in pulmonary function that causes a buildup of CO2 in the plasma and as a result will lower the pH. This could be due to asthma, emphysema, or chronic bronchitis. It could be due to trauma or damage to the brainstem. This would have an effect on the respiratory control center. It could be due to drugs that depress the central nervous system. Renal compensation can take several days to restore the pH balance. However, if there is also renal disease involved, then the person will not be able to compensate and you will see a very severe increase in acidosis. Traits or symptoms: weakness, confusion, disorientation, coma, and death. Respiratory alkalosis is due to excessive pulmonary carbon dioxide clearance. This can be due to hyperventilation to compensate for hypoxia or breathing air with a reduced pressure, for example, when you travel to higher altitudes. It could be due to disorders of the pulmonary interstitium that results in hyperventilation. Or it could be due to anxiety and psychogenic disorders that result in hyperventilation. Symptoms would be numbness, increased sensitivity, lightheadedness, and tetany. Metabolic acidosis. This is due to an increased production of acid metabolic products. This could be due to hypoxia. Prolonged hypoxia will result in lactic acid production, a shift into lactic acid metabolism. Could be due to ketoacidosis, which produces keto acids. This is common in people with diabetes mellitus. Renal failure, where there is a decreased ability to excrete hydrogen ions. Thiazide diuretics, which result in an excess of acids. Chronic diarrhea, which can cause a direct loss of bicarb. Or intestinal fistula. This results in a reduced intestinal absorption, which can result in a direct loss of bicarb. Symptoms include rapid and deep breathing, generalized weakness, fatigue, and central nervous system depression. Metabolic alkalosis. This could be due to acid lost from the GI tract through vomiting or diarrhea. It could also be due to a renal mechanism related to the use of loop diuretics. A loop diuretic is given to cause water loss, and it works at the level of the loop of Henle. What it does is it will block sodium reabsorption in the loop of Henle. If you don't reabsorb sodium, you won't reabsorb the water. But then when the fluids come around to the distal convoluted tubule, these diuretics cause the sodium to be reabsorbed at a very high rate, and this will result in hydrogen ion losses. This often is not likely to develop without some factor that compromises renal bicarb compensation. For example, volume depletion will result in a pronounced sodium reabsorption, and bicarb will be retained to balance the charge. It could be due to adrenal cortex tumors that hypersecrete aldosterone, and as a result, hydrogen ions would be excessively secreted. And it could also be due to increased antacid therapy. Symptoms are very nonspecific: anorexia, nausea, lethargy, loss of mental acuity, and loss of consciousness. This is just showing the 4 scenarios and in flowchart form and how they will result in an acid-base imbalance. Compensation mechanisms. The body is going to try to compensate, and the 2 main ways are through changes in ventilation and changes in renal, hydrogen ion, and bicarb excretion. Compensatory mechanisms can complicate the diagnosis. For example, you can have acute metabolic acidosis due to renal failure, but this would then activate hyperventilation. This will reduce the acidosis, but end up shifting the equilibrium. So we describe a condition as being uncompensated if no compensation response is seen. Partially compensated means the pH is coming closer to normal, and fully compensated means that the pH is normal, but other ion imbalances may also be present. And again, this is just the same flow chart showing compensation. Therapy for acid-base imbalances: try to adjust the pH of the ECF using either oral or IV administration of different agents. For example, you can use oral sodium bicarbonate to treat acidosis. You can use oral products that will be metabolized to form products that can result in pH shifts. In acidosis, you want to use sodium gluconate or sodium lactate. These are metabolized to release sodium, and this will help to retain the bicarb. In alkalosis, ammonium chloride will produce acid products that will offset the alkalinity.